quick disclosures, nothing major, but pretty much I guess everything's going to be relevant because laterals, obliques, robotics, is majority of my practice. So we have now accepted that the use of robotics navigation comes in very handy in the kind of traditional cases where we got to put the pedicle screws, like in this instance, severe trauma to the thoracic spine, and fixation with the pedicle instrumentation. Robotics help here by allowing us plan the best trajectory, the best length, thickness of the screws, so that now you get the construct that has maximized within the patient's anatomy. So that's without a doubt. We know it works. Prone position, beautiful work, especially if you're doing perc. Always a little more leery on the open because the soft tissue retraction you have to fight with the robotic arm. But overall, yes, we got it, right? We can do it in the prone. The robot has helped me a lot with my single stage lateral. Martin has done a great job, so I'm not going to steal his thunder on the on how we do it. Pretty much very similar approach where simultaneous exposure, the oblique approaches to any of the lumbosacral levels is done while the screws are being placed. And that cuts on the time, makes the surgery a little more efficient. Now you don't have to stage it anymore or separate over several days. And so far, we've been having very great experience. One thing I would recommend, Martin, I guess, is the look first and see what you can do with that arm once you're done with the screws. Here you can see we actually keep putting it to work. I call it $1 million retractor. It was nice to see Globus and Pantheon kind of come together and allow me connect the two. So now the arm is holding the retractor system once the screws are done. And that arm is pretty rigid. It's built to be stable in place and no one can really move it. So why not use it for the retractor on these oblique cases where there's a lot of tissue manipulation, a lot of movement, things always slip. So I found it very helpful. Maybe a little bit overkill for what technology was intended to be, but it does help me with the flow. And trust me, I've gone through many retractors, many systems, many approach exposures, and I know what I'm talking about when I say this robot does work at holding it well. Let's talk about some of the more obscure cases. And here we can agree that we don't have to agree on what I present. This is more of a technical note. We've had this robot for a year, so none of my data has a long-term follow-up, right? Yet I can't present ODIs at 1 or 2 years, fusion rates at 1 to 2 years. I'm going to present the feasibility of the technical aspects of using the robot in something that's outside of the pedicle orientation. Now, we take the technology as something that's rigid, tubular, and you can align it with any line in space that you can draw. So why not start drawing lines everywhere else that we may use it? Here's a typical case. The case presentation that I hear, I've jumbled the images on purpose just in case, because we are on the, this is going to go online, and for HIPAA violation, I don't want to be able to trace anyone to a particular person. So here's the typical case of an unstable odontoid fracture. And let's say you elect to go anteriorly. And there's usually considerations that we take in approaching that surgery, the line of direct screw placement, what's in the way, patient pathology, post-op swallowing, and all those issues. But let's say you've decided to go anterior and we have the robot now. How do we do that? Where before, with standard, maybe biplanar fluoroscopy, the main consideration is making sure the line of instruments can really get through the anterior C2 body and get into the fracture dense fragment. Here we have to also consider for the O-arm spin, for all of that technology that Martin showed in the room, all of that footprint that it can accommodate. So I'm using the carbon fiber Mayfield because we're going to be doing a 3D spin. The less artifact, the better. The double articulating, again, carbon fiber arm allows it to be flatter overall, and there's no elbows sticking out into the space that would limit the inner diameter of the O-arm. And of course, you still have to keep in mind the chest line, because in the robotic system, you have to allow for a little more space than you would normally do with just a fluoroscopy and straight instruments, and you will see why. The one learning curve, I guess, point with these odontoid screw placements is the exposure should be very tense-free. And ideally, if you can place the retractor, maintain the visibility of approximate line where the screw will go, and allow that to stay in place while you're doing the 3D spin. So there's very little manipulation between the 3D spin, registration of the arm, and the robotic system, and actually doing the steps of the procedure. That would be the best. I've had cases where I had to abort using the navigation because the soft tissue was too bulky. We didn't realize that even though we were exposed down to C2, did 3D spin, but then to actually get in line, had to manipulate a lot of tissue. And of course, even with Mayfield clamp, there's a lot of movement and a couple of degrees off, and you can't rely on that navigation anymore. So if you can get to this position where you have a retraction in place at keeping your line of sight intact, you'll probably be more successful using the robotic system for this procedure. Chest line consideration. Remember how I said a little more adjustment here. The arm has its own volume, so it's not just a flat screwdriver that you have to place against the chest anymore or sternum. You have to accommodate for this whole bulky arm, and of course that limits how many patients you can apply it to. Got lucky on this particular case where a patient had a high T1 slope from the thoracic kyphosis, so their neck was really forward, and that was partly what contributed to their fracture. When they fell backwards, no room for the head to move back, and they just hyperextended. So got lucky that the robot was perfect for that particular patient. Other patient had to cancel. And here's just how it looks when the robot's holding the arm, and you can do fluoro guidance as well, where you can trust the system. And this is what we're doing right here, following the robotic arm and just trusting it. Our plan, since the software is not really designed for a dense screw, this is the pedicle screw that's being planned inside the C2 and dense traversing the fracture site. And really all we need is just that straight line, so we can put our drill and then we can follow with the small screw. The screw was placed outside of the robotic system as well because there's just no instrument set up yet to allow it to go through the arm while holding the narrow screw for the dents. But on the right, you can see the outcome. Again, whenever there's a positive outcome, there's always a chance of just being lucky. And probably got lucky on this one. Looks pretty right in the middle, very full and even, and achieved what we wanted to do, right? Would that be able to, can I reproduce that in many other cases? Probably very unlikely, right? So I'm taking all of that with a little bit of a grain of salt, as well as sharing this with you. Even though it looks cool, don't do it at home right away. At this point, I have a 6-month follow-up with this patient. You can see that the alignment is preserved. At best, I can say that we haven't failed yet, right? And then, of course, you can start looking and hoping that maybe there's a little bit of early bridging bone. And the good thing is the screw is still in there. It's not windshield wipering. It's not being swallowed within the pharyngeal tissue, right? So far, so good. Let's see how it goes in the future, all right? But this is the first technical kind of share that I'm doing here, almost kind of in this private setting, although we're all going online, but big cautionary warning, don't do that at home, right? There's a lot still to be adjusted. But let's keep pushing. At the University of Miami, with the Miami Project to Cure Paralysis, we have a large cohort of spinal cord injury patients, acute, chronic, subacute, and of course with different pathologies that come with it. Here, one of the examples, a Charcot joint formation usually happens in the mid-thoracic area. That's a point of articulation for a lot of these patients that utilize a wheelchair and kind of use their whole body to move the wheels. They can create dish above and below, but with a continuous disruption of that one segment, they just develop this inflammatory joint. It really has a different pathophysiology and even biochemistry on the inside versus a regular spondylosis or degenerative disc disease. There's a true inflammatory tissue in there, very little cartilage at that point. So how, different ways of treating it, right? There's no right or wrong. Many would do it differently. But here, we like to reinforce the anterior column or allow it to at least the possibility of fusing. You can do transpedicular decompression, drill out the pedicle, remove a little bit of the rib, get in there and do all that work, which is, of course, is always time, blood loss, and considering different comorbidities of the patients that will all accumulate and has to be retracted or reflected in the preoperative planning. What the robot allows me to do on the same case, I can plan as if this is, you can see the screw that's being planned, but I can plan an extrapedicular or transpedicular kind of oblique access at the junction between the rib and the vertebral body, but allowing me that trajectory that would get me into the disc space, which is mostly filled with fluid, with inflammatory fluid. And so the robot is navigated in that direction. And you can see how it looks intraoperatively. And I'm using the same steps as I would for the pedicle screw, using the drill, the rimmer, getting into that space. And now I have a clear channel and I can put that funnel down and fill it up with the bone graft. or biologics. And you can see on the right how that disc space is grayed out, especially more on the lateral, how I'm able to fill that space up. Of course, this is a deviation from the norm, right? This is not a straight line pedicle orientation for the robotic system. There's still a lot of instruments that need to be further adjusted and developed to make this step a little more, I would say, higher quality. But at least it's a beginning. We're able to navigate, putting those lines in the non-traditional, just pedicle orientation. Let's move on. Another not so common, but a pathology that frequently comes in our office, and a lot of times it's usually young adults, 20s, 30s, with this predisposition for an isthmic spondylolisthesis. It's that high slope and anatomy of a transitional level, whether it's lumbarized S1, sacralized L5, with everything that comes with it. That disc space is so vertical, or I guess horizontal, when patient is prone, where considering doing a T-lift or A-lift is out of the question. You can't really access that disc space for any of the inner body. Normally, and I have, that's why I've been trained and that's what I've been doing before, it would be usually a two-stage procedure, front and back, doing a reverse Bowman through the front with a fibular strut that would traverse the two listhetic segments, and then screws in the back. And patients do well, right? The goal for these cases is really have a strong construct that will last, that will hold long enough for the fusion to happen. It just also happens if we start getting cute and minimally invasive and do less than the body needs, very few we just see common pseudoarthrosis or the construct fails because the forces are slightly different than what you see in the standard degenerative lumbar spine. With the robotic system, I have been trying this now, and we actually have a combined case series with Dr. Nicholas Theodore. He's been doing this as well. When we discussed it, we kind of serendipitously found out that we've been separately doing this. So now we just got to collect a little more time and see and hope that they don't fail. And if they don't, it'll be great. But this is kind of the preoperative planning of an MIS technique, percutaneous versus a two-stage procedure, prolonged hospitalization, painful recovery. This is all done in prone, percutaneously. And I'm going to take you step by step of what I actually do. Some of the considerations, of course. Planning, as Martin has mentioned, where you place your navigation array, where everything goes. If you don't do it well, eventually it can interact with each other. You won't be able to successfully navigate. So here for the navigation array, I kind of keep it on away from the spine within the dome of that iliac crest, because iliac crest would limit any of the trajectory. So if I can stay on the outside of that, I know the arm can get in as well. Some of the anatomical considerations of patients that come with this condition of just high sacral slope, high degree of isthmic spondylolisthesis, is that their traditional anatomy, and just some of the pictures of the setup, the traditional anatomy has some peculiar points to it. So for instance, the L5, like for instance, in this case, you can see this axial slice. Look how medialized those pedicles are. In this particular case, this is probably more of an S1 orientation, a lumbarized S1 that appears like this. And on the right screen, you can see the starting point where the robot puts the navigation tube. Imagine doing this through a midline incision. You would have to have probably 1 foot long incision to be able to retract that far laterally, or you would underexpose and then fight the system, fight the soft tissue, skive outwards, or compromise and decide, okay, I'm going to place those screws a little more vertical and go through the facet joint, and now you're compromising the level above, or have a very short screw. So having a percutaneous approach eliminates all of that. I can put that robotic arm anywhere where I think is best. And you can see how far lateral that goes just for this particular screw. And then planning it, I can maximize the length, the thickness, and just overall orientation. And later I'll show you how the tulips are placed as well. So that's the L5. Coming down to the transitional level here, this is something that's has been published and we've seen it. It's not really popularized, but having a screw trajectory that goes across the disc space from one vertebral body into the other. The benefits. Orientation of the patient with a listhesis, high sacral slope. That screw is pretty much vertical when patient is prone. It's up-down orientation overall. Easy to plan, easy to execute. Of course, there's always a question, what do we do with the disc space? Before placing the screw, I use that same funnel in that same channel that was created by the drill, and I fill it up as much as I can with the biologics. Will it fuse? We'll see. Like I said, there's not enough time yet to show you the long-term outcomes, but early reports are very favorable. But technically, this is a screw that goes starts at the bottom of the pedicle of presumed S1 level in the direction of the disc space towards the bottom of L5 segment that's least teeth forward, with the tip lodging into the cortical surface of that particular end plate, and therefore I call it a tricortical screw. It enters, exits, and enters again. We'll move on, and then I'll give you a few more considerations for the actual orientation and angles in the later slides. And then the final screw that robotic system or any navigation system allows me to place is really maximize the use of that sacral bone without, in this particular case, penetrating the sacroiliac joint, but using that alar segment of the sacrum through the S2 starting point. With the robotic system, I can really place that screw. And when it goes in, you know how that tactile feedback of the creaking screw and the instrument about to break out, it goes really well. It's a really nice anchoring fixation overall for the construct. So now you have 3 points of fixation, and I did not have to touch the level above the 4-5. The S2 alar screws go through a midline incision, and now that same midline incision that you can see on the right screen is minimal, but it's enough to get down to the posterior lateral aspects, do whatever decompression of the gill fragments, remove all the bony fragments, decompress the nerve roots, and also lay posterior lateral graft. Again, not requiring that foot-long exposure otherwise. So when looking at both preoperative plan and how it looks, in the post-operative, the robotic system allows you to do exactly that. What you plan is what you get, especially if you have a nice rigid anatomy that doesn't move, very difficult to make a mistake. Some of the planning considerations for this technique, of course, keeping the tulips in line. I just want to have a straight line, a straight rod that can be passed along, and it goes in a very oblique fashion. You can imagine it's very deep in the patient and goes away from the surface. On the tricortical screw, the consideration should be when you look at it in the lateral, there's a limit to how much a tulip can accommodate with respect to the angle of the screw. Put this here, right here. So different systems will have, I guess, different screws and what they're allowed to do. This is one thing that I keep in mind. Will my tulip get well in line with the rod, and I'll get a nice placement of the rod that's going to really be sitting well, or the tulip going to be angled, and I'm just going to be using the friction forces of two edges holding onto the rod. And that's what has to be kept in mind, how far that angle is. But overall, you can see it's a linear alignment of the tulips that the robotic system allows to perform. And now the case that with fluoroscopy navigation may require a lot of sweat and tears and a lot of cognitive kind of involvement. This is done me and an intern. We're talking about World Cup, and we can just progress by just letting the robot navigate for us. Okay. And early on, patient goes home. 2 nights after, on the second day, we keep in touch by phone. So far, so good. We'll see in the long term, and that's just, of course, stay tuned. So the cases that I've shown you now, pedicle screw placement, yeah, we got it, right? Robotics work. Prone, lateral, great, they work. Odontoid screw, I'd be very cautious. It's a cool technique, but not something that even I would consider for every patient. This is just really pushing the limits of what the robot can do for us. There's still a lot of work, but I would not advocate for this just yet. Transpedicular or extrapedicular access to the disc, very feasible. We can get there. Still need some work on further some of the instrumentation that we can use so we can improve the disc prep if there's any, or further improve that actually construct. And the same thing with the transdiscal, transcortical type of approach. There's still many considerations and many instruments that need to be adapted to this to really get to that Listis level and see if we can make it even stronger while maintaining the minimally invasive aspect of this. All right, so those are my cases that are kind of out of the norm, a little crazy, right? But of course, calculated safety. This is not like we're just going off with tangential here and doing thoughtless things. This is, we planned it all out, we practice them, and we'll get them done. So far, so good. Thank you.
Thank you. Thanks, Timur. You're truly expanding the frontiers in Miami. We're going to move on to our demonstration. So enjoy the World Cup today, and hopefully we'll see you soon.
Thank you. Thanks for having me over.